Good afternoon, everyone. We have what I consider a very exciting afternoon schedule here. We're going to be traveling north to begin with. We're going to Nome, Alaska with our first presenter. Then we're going to travel into the Sacramento Valley and listen to trauma-informed. How do people that previously lived in a conflict zone, how do they adapt to dementia, and how do their caregivers offer response to that? Then we'll go into the needs of the Black community and how they're being so well addressed by a program. So I'm going to hand this off now to our first speaker, Christine Schultz, who is in fact running a program up in Nome, Alaska. So hopefully you're there, Christine. I know you're in the Zoom room, and I'm going to let you take it away.
Yes, I am. Good morning, everyone. Thank you so much for this opportunity to present today about the elders that we're serving here in our area. I do have a slideshow. I believe it was going to go through the slides as I said next slide. Not sure if that is queued up. Helen?
It is coming.
It
Hold
is
on
coming.
just a
Okay,
moment.
great.
52% and counting.
So if you've heard of Nome, you've probably heard of the Iditarod sled dog race. We are the end point of the Iditarod. Everybody's like, wait, Nome? That's us. And
Christine, why don't you just give us a little bit of who you are?
Yes, I was going to start with that. So I'm coming to you to talk about a program that we have here to assist our elders in our region. Elders is the respectful term for someone who is the age of 60 and over, soon to be me in a couple weeks. Our program is focused on dementia and trying to make sure that we don't have any cultural loss by having any unnecessary out-of-home placements, and can provide dementia care to patients in their home in our region. So I'm Christine Schultz. I'm the Director of Patient Support Services at Norton Sound Health Corporation. So in that capacity, I'm the administrator over our patient lodging system, our medical social work system, our in-home care providers that go into the home, our translators, our chaplains, and a few other little things. Yep, that's me. Next slide, please. This is my amazing team, amazing ladies that I couldn't do this without. Next slide, please. And again, what we're going to talk about today is how we're honoring our elders and serving them in their home. Kind of talk about where we live and what we're providing to those elders, and what our Indian Health Services Dementia Grant is allowing us to do. That is a picture of the Northern Lights, which is what they look like here. Next slide, please. Here's where we are. I think it's obligatory for any presentation about Alaska to start with this picture. Sorry. So that's Alaska superimposed on the lower 48. The circle is our area of Alaska that we serve. The reason that I put it up here is because I want everyone to appreciate the actual breadth of the region that we're serving. It's the size of West Virginia, with 16 communities spread out that we're providing services to. Next slide, please. So this is our region itself. 15 villages ranging from 90 to 835 residents. Nome itself has a little under 4,000. You have to get here by air. There are no roads to get to Nome. So then you have to come in a big jet and then go in a little plane to get out to our villages. Next slide, please. Here's who we are. These are the people that we're serving. We're at a confluence here. We have 3 Alaskan, whoops. Go back a slide. Thank you. We have 3 Alaska Native cultures that we're serving in our region. Inupiat to the north villages, Central Yupik to the south, and St. Lawrence Island Yupik, which is related to Russia, to our west. We represent 20 sovereign tribal governments, and our regional population is about 75% Alaska Native. I'm going to stop here and say I'm very honored to be doing this presentation. I am not Alaska Native, although I have lived in the region for over 30 years. And I am honored by the trust of my corporation to be presenting to you on behalf of our elders that we serve. Next slide, please. Subsistence, I want to mention this because here it's really not a cash economy in most of our villages. So the elders are getting food because people are hunting and gathering for them. So you have some lovely photos of some dried salmon, a moose, and some okpiks, otherwise known as salmon berries or cloudberries. Next slide. Norton Sound Health Corporation, I wanted to put this in with our mission and vision because it's really about honoring our core values of integrity, cultural sensitivity, and respect, and always improving. So our program isn't perfect yet, but we're trying. And I want to present today about the efforts that we've made so far. This is a hunter on an ice floe waiting to go seal hunting in the spring. Next slide, please. Our governance is made up of a consumer-directed board. So one representative of each of the tribal communities that we serve makes up our board. So patients have direct access to their board members and can present any concerns, suggestions for improvement to their board member, and they bring them on to us. Again, you have to travel to villages. One of our villages you have to get to by helicopter. And then in turn, Norton Sound is a member of the Alaska Native Tribal Health Consortium of 229 tribes. So Alaska Native Medical Center provides our tertiary care. Next slide, please. Norton Sound Health Corporation, here is our hospital. We're very proud of it. We moved into a new building in 2013, so that's a new hospital. We are a critical access hospital. We've got 18 acute care beds, including a swing bed program, did about 1,000 admissions a year. Have a booming primary care clinic where we do almost 17,000 appointments a year. We're a level 4 trauma center with our ER, and then we also have our own emergency flight team to take people from the village to Nome or then from Nome on to Anchorage. Plus ancillary services and an 18-bed long-term care center, which is about to be expanded to 30. We are mid-construction as I speak. Next slide, please. So here's a picture of some of our clinics. We have a clinic in every single village. This is how we deliver healthcare. They did over 28,000 villages last year, and 2 of our clinics are a little bigger and have some additional services because they're in our larger villages. Next slide, please. So our village healthcare, want to point this out because there's something very special about Alaska village healthcare. We have what's called community health aides. Those are paraprofessional health providers that are trained in a training center. They advance their care provision as they go through different training modules, and they provide the bulk of primary care to our patients in the village with physician oversight and sometimes also a physician assistant on the ground with them. Next slide, please. Through the patient support services, these are what we're providing: medical social work, patient lodging. Again, if you have to fly to Nome, you have to have someplace to stay. So we did over 13,000 bed nights of hotels. I've got 2 hotels for patients. Next slide, please. So social services itself, we're doing things that medical social workers everywhere do. A lot of complex discharge planning, including new placements, advanced care planning. So if someone needs legal representation, if they can do a power of attorney, if they need guardianship, we're helping them apply for any resources that they may be eligible for, and then also serving bereavement services. So we had about 7,000 patient encounters a year through social services, so medical social work. Next slide, please. So here's where we really are providing help to the elders besides the social services program is through our in-home care coordination program. And the 2 ladies at the table there are 2 of my managers for the program. And they did about 700 patient encounters a year. Next slide, please. And here are some of our direct service providers. So proud of these ladies. These are our personal care attendants that are going into the home and providing services to our elders. And they did over 2,500 home visits in the last year. They're funded by a variety of sources. We do take Medicaid for the Medicaid waiver programs. We also can have Medicaid fund personal care services. The grant itself is being used for respite care. And then we also are having some board designated assets that I can use to provide respite care to elders while they're waiting to get on Medicaid. Next slide, please. So this is the program I want to talk about today. We are one of the grant awardees for the FY23 cycle of Indian Health Services for their dementia grant. We are part of the 2nd cohort. The goal of our grant is to honor our elders by making sure that they get what they need at home and can stay in their community of choice, because we want them to pass on that hard-earned wisdom to younger generations, and we want to honor them by allowing them to have that choice of where they want to live as they get older, and to be able to provide dementia care at home. So we have 5 drivers of care. I'm going to go through the 5 drivers of care and kind of what we're doing in each of these areas to try to be addressing dementia, and then kind of wrap up at the end with sort of some of the challenges that we've had and our vision for the future. So next slide, please. First driver is you can't serve dementia if you don't know what it is. So increasing awareness and recognition of dementia. We've been doing a lot of health fairs. We've done health fairs in every single village in a 2-year cycle. We also do a quarterly newsletter. There's no mail delivery here, so every household in the region gets information on healthcare, and we're making sure that we have dementia-related care with brain health in those quarterly newsletters. So here we are getting ready to get on the plane to go to the health fair, and then that is one of the patient support staff at the health fair. We make sure that all the little kids come through the health fair for the village as well. Next slide, please. So we have challenges. I'm going to go through each of our 5 drivers and kind of talk about the things that we've had challenges with and kind of our solutions. We are a program that is in development. It's just been 1 year, but we're proud of our efforts so far. And I think that it serves as a good basis for other similarly based hospital programs that might be able to try this too. So biggest problem is we're hospital focused. We're taking care of lots of patients, so we don't have a lot of time to be putting on huge events, but we're going to be partnering with our senior center, which does congregate meals here in Nome, and also our senior housing to try to do really an elder specific health fair at elder congregate locations. In the village, the elder congregate meals go through the school system, which is amazing because that means that the elders get to see the kids every day during the school year. We're also using our primary radio. So here, radio really is still a thing, and all of the households have their radios on. And so we're doing a series of elders talking about brain health in their local languages. Local languages here were not written, so it doesn't make sense to translate things into writing, but it makes a lot of sense to make sure that our elders are talking in their native language to other elders over the radio. Next slide, please. So second, we want to make sure that since we know about elders and we know about dementia, that we're making good diagnoses. So what we've done is we've instituted a multidisciplinary team here in the hospital setting that goes through and assesses elders. We've standardized our tools, so we're using slums primarily. We're making sure that all that information is going into the EHR. The great thing about our EHR is that it's a system-wide EHR, and so we can use it in the village, in Nome, and or tertiary care through Alaska Native Medical Center. So it's seamless continuity of care in our EHR. We're providing education to our staff, and Dr. Bruce Fink, who of course most of you know, provided education to her staff last year. We're seeing that about of our active user population, which is Alaska Native patients seen within the last 3 years, that about 1.1% of that user population has a diagnosis of dementia. And that picture, for those of you who are wondering what that animal is, that is a musk ox, and they do live here. It's in the fall. Next slide, please. These are blueberries. So really the big challenge that we have here with making accurate and timely diagnoses is that we can do a lot of primary care, but we need to have neuropsych testing capability, and we don't have that because we don't have a psychologist. We are hiring one, however, and they're going to be starting this next quarter. Next slide, please. So third driver, we want to make sure that we're doing everything that we can in a coordinated effort, and that the ancillary services are chiming in, because it's not fair to diagnose someone with dementia if the problem was that they couldn't hear or that they couldn't see the test. So we're making sure that ancillary services are also assessing the patients, and that way when we make a diagnosis, it's a true and accurate diagnosis. So that is our physician champion for our team there in the photograph. He is the doctor on the left, Dr. Ryan McLean. Next slide, please. Next step for us, again, we're hospital-based. It's really great to get providers in a meeting. It's pretty easy to do that. But the real next challenge for us is, how do we get services into the home? We have personal care attendants. State is usually only authorizing about 15 hours a week for those elders. And we want to make sure that more elders are getting assessed in the home, so that even services like environmental modifications and grab bars in the shower and things, even the little things, that we've got a way to do that. We don't really have a good system. Our health aides are very overloaded with the care that they're already providing. So we don't want to put them in a position where we're saying, great, and now you get to do a home visit on every elder every week. So we're trying to figure out how we can get more services into the home. In the meantime, if we can't get to the elders, we're having the elders get to us sometimes. So we are using our acute care swing bed program for admissions so that we can do evaluation and assessment of patients while they're here. And then also, of course, we have the Medicaid and Indian Health Services funded travel and lodging that they can stay at. Next slide, please. Next, once we've evaluated them, we've decided that they have a diagnosis of dementia, we want to make sure that all of the services that we can provide are being provided in a coordinated way. So again, the multidisciplinary team is meeting monthly, evaluating at least 4 patients a month. And then we're involving the primary care provider in those evaluations and making sure that we're keeping in contact with them as they implement those recommendations. I'm happy to say that 2/3 of our diagnosed patients have actually had a clinical care encounter during the last year. We'd like that to be 100%, but we're pretty happy that we're up to 2/3 already. Next slide, please. So the big challenge here with making sure that we're doing coordinated care over time is that we live in a very remote place. And so we have a problem with consistency in patient contact and follow-up, because if our providers are all month on, month off, and then the nurses are month on, month off, and everybody's on a different schedule, it can be very difficult to provide that care in a consistent method. Again, the good part is that our standardized EHR can make that a little bit easier. And then also our physician champion is creating a standardized order set so that all incoming staff, incoming providers have that and know which labs to order, what services are available. And there's a little more continuity that way. Next slide, please. And then the 5th driver of our program, what we're really trying to implement is we all know that a patient with dementia, that dementia is going to increase and the caregiver burden will increase. So the 5th driver is how can we support caregivers as they're helping their dementia patient? Social services, in-home, patient benefits, we're all trying to coordinate. So again, legal representation for the patient, making sure that any resources that they can be eligible for are applied for, helping with advanced care planning, and then actually putting patients at center, right? So our elders are going to be our primary focus from the villages for us. It's going to be the primary focus for our in-home programs. Elders take priority. And through the grant alone, we've done 175 hours of respite in the first year. And then through our other funding sources, an additional 1,500 hours of respite. I think that the big impact here is that the more that we support caregivers, the more that we can prevent out of community placements. We do not have an assisted living in Nome. We do have long-term care. So if you need that next step of care, sorry, it's going to be a little dark, sorry. I have a motion detector lights. If you need that next step of care, you could go as far as Anchorage. And we want to make sure that that doesn't happen and that we can keep folks in their own home. And then if they do have to go into care, that goes into long-term care here in Nome where the families still have access to the patient. So I put this quote in, this is one of our elders, because he had said that with the personal care attendants going in and providing care and helping with chores, that he had felt like his house was a home again. Really touched our program. That is the goal of our program. We want to make sure that all of our elders feel like they're at home and can stay at home. Next slide, please. So here's some of the challenges. We don't have a caregiver training and support program in region. We'd like to develop one. In the meantime, we're referring to online resources through the Alzheimer's Association and Alzheimer's Resources of Alaska, because they do support groups, they do caregiver training, and at least it's something. Environmental supports, again, we want to make sure that if people need grab bars in their showers or anything else for home modifications for handicapped accessibility, that we can do that. We don't have a lot of contractors here, and so that's been very difficult to arrange in the villages. And then the third one is we have some barriers to employment. We have a lot of elders right now that are on a waiting list. We haven't been able to get caregivers for them through our program, personal care going to the house. So if we can get more of our vacancies filled, then we can be providing even more care to elders. So workforce development really is one of the solutions that we're working on as well to meet that challenge. Next slide, please. So all that being said, I think we can get there. I think that our region has some amazing strengths. This is a wonderful picture. These are elders that were caroling in the spring. You'd think at Christmas, but that picture is too light to be at Christmas, so it was in the spring. I think that one of the strengths of our community is that elders really watch out for each other and the community watches out for the elders. So if we have patients with dementia that have started wandering, the community is really very good about making sure that they get back to their home, that the clinic knows that this has become an issue for the patient, and that we're trying to put services into place. Subsistence hunting is also a way to support elders. Again, it's not really a cash economy up here, and so subsistence is very important. The state even has a proxy hunting system so that young people can go out and hunt for elders. And it is tradition that when someone goes out hunting for the first time, that the meat that's harvested does go to an elder for that first hunt. Again, we're supporting elders with lunches at school. There's a lot of interregional collaboration between programs. And then there's also real strong support for education. So we have a certified nurses aid program, we have personal care attendant programs, we have an associates in nursing program, all in-house here at Norton Sound Health Corporation. And then the last one that I'll mention is multi-generational housing. Pros and cons to that, but the pros are that you have a caregiver in the house with you and that your wisdom can be passed on to the younger generations. Next slide, please. I kind of had fun making this slide. These are logos of all of our partners. So we're working with the University of Alaska system in both Fairbanks and Anchorage, with Veterans Administration, our Alzheimer's resources in Alaska, and then our sister agency, COERIC. COERIC does social services, Norton Sound does health services in our region, and we partner and even have joint board meetings. Next slide, please. So given the strengths, we do indeed have challenges. The first one, again, was that first slide that showed you how big an area we serve for the remoteness and weather. We are at the Arctic Circle, so we have a lot of blizzards. Also, because of the remoteness, everything here is very expensive. So the cost of living is very high. The cost of having housing is very high because everything has to be imported. We're on the tundra. There are not trees. You can't just build a log cabin. If you have a person that's in placement in Anchorage and you live in Gamble, that could be a $1,400 ticket round trip to go see your loved one. And so then loss of contact with family is one of the challenges we want to make sure that we avoid. Also, 5 of our villages do not have running water and sewer. So what that means is that then when you're saying that an elder needs chore services, those are heavy chores. Hauling water, hauling trash, hauling human waste, sometimes chopping wood. Which is driftwood, by the way, since there's no trees, and removing snow. And so with the heavy chores, sometimes just having someone who can do the heavy chores is enough to allow that elder to remain in their home placement where they want to be. Next slide, please. So to sum up, here's where we'd like to be in 10 years. We'd like to have this program continue. We'd like to have it be sustainable with or without grants. We want to make sure that we have standardized dementia care in all of our clinical settings across the continuum of care. We want to make sure that we have increased capacity for cognitive testing and can do all of that in-house. We really want to help make sure that the region understands the importance of early recognition so that we can get supportive services in and allow that elder to have the longest amount of time at home as possible. We want to make sure that that care is coordinated and nothing ever slips through the cracks. That's kind of a high goal, but that's our goal, is to make sure the care is always coordinated. And then that we have a way to make people's homes safer for them as they age in place, especially if they have dementia. Next slide, please. And that's us. So again, if you've heard of GNOME, you probably have heard of GNOME because I did a dog sleigh race. So I am finishing with the slide of one of our dog teams practicing for the race. I'd like to very gratefully acknowledge the support both of my own board, who's been very, very interested in helping our elders, and then also Indian Health Services for this grant opportunity. Thank you very much.
Oh, Christine, you've brought an essential perspective here today. Those of us who live in the contiguous 48
Yeah.
haven't necessarily understood the unique conditions and sometimes very extreme conditions that our northern countrymen experience. So I think it's been vital for us to have this exposure and what you've done with little. I know that funding through Indian Health Services has expanded and allowed this program to launch. And I also want to acknowledge Dr. Bruce Fink, who, um,
Amazing.
he put your name forth to me because he could tell that the strength of the program, even though it's in its early years of funding and development, really was speaking well to the community and the needs and respect of the elders in that area. So I'm very, very happy to have had you here with us today. And if you would please hold on, we will be having other presentations, but we'd love to have you join the Q&A.
Yes, absolutely. And thank you again for this opportunity.
All right, thank you. All right, we're going to our next speaker is Dr. Wayne Meyer. Dr. Meyer is with the University of California System at Davis. And I'm going to see if Dr. Meyer is going to come up here on the screen.
Yes, hi, I'm here.
Oh, hi, Wayne.
Hi.
Um, I'm going to let you go ahead and introduce yourself because you have also another unique program. And as we've spoken about in private conversation, this is very close to my heart, as I have a Vietnamese nephew. So I'd love to hear more about what you have going on in the Sacramento Valley.
Great, thank you so much. Do you see my note slide or the presentation slide?
At this
No.
point, I only see speaker
Okay, let
slides,
me
notes.
swap how's that?
Very good.
Oh, wait. Okay, sorry. No, I can't see my notes. Just one second. Um, you would think
If
that
you
I'd
like,
always see
Wayne,
it,
if you
or
like, we can click them forward for you and you can hold your notes up. Would that help?
let me try one more time.
Okay.
How's that? Can you see
No,
my presentation?
uh, no, not in the same way. It's in
Oh,
speaker mode still.
oh, shoot.
Yeah, we'll go ahead and share it for you.
Okay, that would be
Okay,
great. Thank you.
just
I
cue us.
appreciate it. Um, Great. Thank you so much. So, thanks everyone for allowing me to speak today. I'm Wayne Meyer. I'm an associate professor in the Department of Neurology at UC Davis. And I'm really happy to be here today to see some familiar faces and also see and meet some new people and hear about these just great presentations. So I'm honored to be here and to talk a little bit about some of the research that I've been doing along with colleagues and community-based partners in Northern California. So I am trained as a social psychologist. I lead the research education component at our Alzheimer's Disease Research Center. And I've been doing work around dementia and health disparities, particularly in Asian American populations for some time. And so I'm really excited to share some of that work with you here today. Next slide, please. So a lot of you may or may not know this, but Asian Americans are currently the fastest growing racial group in the US today, numbering at about 24 million as of 2022. And altogether, they account for about 7% of the nation's population. So it's a large group that consists of about 30 Asian American and 20 Native Hawaiian or Pacific Islander groups, or AANHPI. And so it's a large group, but it's also a very diverse and heterogeneous group in terms of country of origin, language, immigration history, and socioeconomic status, or SES. So we tend to clump when we talk about AA and HPI groups together. We tend to group them as if they're one monolithic group, but they're actually quite diverse. Next slide, please. This is just a slide to show you some of the larger groups and as well as the smaller Asian groups. So this is as of 2021. You can see here that Chinese Americans are the largest Asian group in the US, numbering at over 5 million. And then Indian, Filipino, and Vietnamese Americans, and so on. So you can see the largest Asian groups and all of these smaller Asian ethnic groups as well. Next slide, please. So there are a significant number of research disparities for Asian Americans, and I just want to pose a quick question to have you think about this. We don't have to answer it, but you know, between 1992 and 2018, how much research funding do you think the NIH devoted to being to clinical research that was focused on AA and HPI participants? What percent of research funding do you think? And you can think about this number in your head, again, knowing that AA and HPI groups make up about 7% of the US population. So maybe it's 6 or 5 or 4%. Well, you can keep going. Next bullet, please. So this was a seminal paper that was published by Lan Duan and her colleagues in 2019 in JAMA Network Open, and they found upon a review of NIH funding that 0.17% of the total budget of NIH was devoted to AA and HPI focused funding. So even though they make up 7% of the population, less than 0.5% of the NIH budget was focused on this particular group, which is quite unfortunate. Next bullet, please. So what about the percent of Asian Americans and Native Hawaiian Pacific Islander groups in terms of representation at the Alzheimer's disease research centers, of which I'm part of one, and there are about 35 ADRCs in the US, and they're sort of the one of the major sources of foundational knowledge that we have about dementia and cognition. So what percent do you think in terms of representation in our National Alzheimer's Coordinating Center database? Next bullet, please. Next bullet, please. So less than 3% of the 50,000 plus participants in the NAC database identified as Asian Americans. So again, really drastic disparities in terms of representation and research in NIH funding for AA and HPI populations. Next slide, please. And I think in large part, this invisibility or lack of focus on this group is due to the model minority myth. This is a term that was coined in the 60s during the height of the civil rights movement by a sociologist who wrote about the success story of Japanese Americans in the New York Times, and how great and how successful they were, and despite having to come to the US and learning the language, that they were just doing so great. And part of this was to pit minoritized groups against one another. And so this myth continues, I think, to this day to perpetuate this notion that Asian American individuals are doing just as well, if not better, than non-Hispanic whites. And so they probably don't need to be included in research. Next slide, please. And I think when we look on the surface, this is showing per capita income for Asian Americans as a group. You can see that per capita income of Asians is about 43,000 compared to whites. And so actually they are doing better. and better than Black, African American, and Latino Hispanic groups. But when we break that down even further by Asian American subgroup, that's where you really see the heterogeneity. Next slide, please. So here you can see that when you compare the different Asian subgroups, there's a wide disparity in terms of income level. Actually, Asian Americans have the biggest income gap amongst all groups. The Indian Americans per capita income is about 57,000, and then Japanese, Chinese, Korean. And when you get to the other subgroups like Vietnamese, you can see that their per capita income is not as high as non-Hispanic whites. And some of the other groups like Hmong Americans have per capita income that's similar to some of the other minoritized groups. So you can see that there is vast heterogeneity in terms of income, socioeconomic status in these groups. Next slide, please. So a lot of my motivation for studying dementia is because of my own Vietnamese background, and I don't know how clear people could see this is an original newspaper clipping. This was in September of 1975 when my mom first came. She's the second from the left. In this picture, she came to the US on April 29th, 1975, just before, a day before the fall of Saigon, before the country fell to the communist regime. She was able to escape with her family because they had US ties. They had ties to the US government, to the embassy, because of other family members who worked there. So she came to the US with her sisters, with her mom. And then soon after I was born, so this is me and my twin sister when we were younger. I'll let you guess which one I am. I'm the one on the left. So people who are thinking left, you were correct. So she was a single mom and she raised the both of us. You can click to the next picture. This is a picture of me and her a few years ago, and she was diagnosed with Alzheimer's disease in 2015. Her mother died from Alzheimer's disease. Her cousin died from Alzheimer's. I had another aunt who recently died a couple of years ago from AD. And so this disease hits home for me. It's very prevalent in our family, and what contributed to my initial passion and desire to study this in the Vietnamese American and other groups as well. Next slide, please. And besides my own just personal experience and history of it, there's decades of research that have shown the high prevalences of depression, of PTSD in Southeast Asian refugees, and in large part because of their experiences of wartime trauma throughout their lives. And upon arriving in the US, a loss of social status. Many were people who were medical doctors or engineers or clinicians in their home country, and then came to the US and pretty much had to take on whatever jobs they could have. And so this, resettlement, these resettlement challenges, acculturation difficulties really contribute to high rates of depression in this group. This was a paper that we published several years ago looking at the California Health Interview Survey data, or CHIS data, which is a statewide representative sample. And we looked at the large ethnic groups in California. And you can see here that amongst the large groups, that Vietnamese have comparable levels of education to white and Chinese Americans, but their per capita income is lower and comparable to Mexican Americans. Levels of psychological distress was highest in the Vietnamese population in California, and they also reported the lowest self-rated health. And so these disparities are really salient for this group. Next slide, please. And I think in large part because they are such a relatively recent immigrant group when you compare them to other Asian American groups that have been here since the mid-1800s, that really it wasn't until the fall of Saigon, and actually this April will be the 50th anniversary of the fall of the country. And so they're relatively recent, and adjustment difficulties and the fact that so many of them had to escape on really such short notice for a lot of them. There are Vietnamese Americans who are now aging who have faced trauma for a lot of their lives, pre-immigration as well as post-immigration. A lot of them were in the war, or if they weren't, they were imprisoned, or new family members who were imprisoned and tortured, or I would hear stories of family members just disappearing. And so all of those stressors, in addition to resettlement in the US, in a new country, many of them face a lot of these traumatic exposures. Next slide, please. So when I started to think about this sort of like lifelong history of chronic adversity and exposures, and thinking about caregiving for someone with dementia on top of that, and just the possible, exasperated disparities and distress that caregivers might face, it really made me think about studying this group. And so this was a small qualitative study that I did when I was a postdoc at UCSF, and interviewed 10 family caregivers to start to understand the experiences of them caring for their family member with dementia in this country. So some of the salient themes that came across from this small study was that one, family could be a source of support as well as stress. So often in collectivistic cultures like Vietnamese Americans, there are multiple family members caring for someone with dementia, just not a single primary caregiver. And I know Dr. Flatt talked about this earlier as well, that it's really a group effort. And while this can be a source of support, it can also be a source of stress as family members are trying to negotiate and navigate caregiving with one another. And sometimes, depending on if it's a parent, child, or siblings, there are really vastly different ideas about the etiology of dementia and what causes it, and subsequently different ideas about how to care for it. So family could be a source of support as well as stress. There was another salient theme of lack of understanding about Alzheimer's disease and dementia, what it was and what caused it. And what I didn't anticipate in, my focus on caregiving and dementia was this theme of loss and trauma that kind of reverberated throughout the interviews when we talked to the caregivers, that a lot of them felt that it was the war, or it was the traumatic escape, or it was being on a boat, that contributed to the person's dementia. And so that was something that came out from these interviews. Next slide, please. And I want to highlight just a couple of articles and quotes. Next bullet point, please. That came out from these interviews. So this was a male caregiver who was taking care of his wife. I think he was in his mid-80s. And he was caring for his wife currently with dementia. And he talks about his time in the war, post-war. When I was imprisoned, it was better to die than to live. I used to bring with me a rope so that when I couldn't handle anymore, I would hang myself. I lived with that mentality for almost 11 years. After I got out, I saw that my family's life was even more difficult because the communists had stripped everything from you. So it was just really poignant that he had gone through so much in his own life, but at that point when we interviewed him, felt this huge feeling of obligation and a sense of reciprocity to his wife, who had also endured quite a bit of loss when he was in the re-education camp. Next bullet point. This is an article that was published a couple of years ago by one of my students, who's now a graduate student at DePaul, where we delved into this data some more. And this is another caregiver talking about their time on the boat when they were fleeing Vietnam. I do remember some of it myself, like being at sea and how our boat ran out of gas, and that we were stranded, paying pirates and hiring pirates to take us closer to the shore, but they just left us in the middle of the ocean. So again, this theme of the war, regardless of whether or not it was the focus of our conversation, continued to be salient in these interviews. Next slide, please. So it really made me think about taking a step back before even engaging with caregivers to study this idea of loss and trauma in this community because it was so salient for them. So I partnered with a community-based organization in Sacramento called Asian Resources Incorporated, or ARI, to begin to build this conversation, build this relationship with them, to figure out how we could engage the Vietnamese community in Sacramento. They had been around for decades and was developed soon after 1975 to meet the needs of the immigrant and refugee community. And so they were a credible source in the community. Next slide, please. And I partnered with them to begin doing brain health and community education in Vietnamese for the Sacramento community. We talked about brain health. We talked about what Alzheimer's disease and what dementia was. We talked about we talked about major risk reduction strategies like eating healthy food, brain healthy foods. We brought blueberries and raspberries, and this is something that I never grew up eating. Blueberries and raspberries and strawberries were not common in the diet, at least in my own family, and so it was brand new to a lot of these individuals. Next slide, please. So we basically went to whatever community would have us. We went to health fairs, we went to faith-based organizations, temples, churches, and this extended to Sacramento, from Sacramento to San Jose as well. Next slide, please. And so that before we even did this intervention with caregivers, and thinking about loss and trauma, we wanted to make sure that we could address some of the major needs that we had heard in these interviews. So the goal of the Vietnamese caregiver study was to adapt and pilot test a culturally relevant intervention. Next slide, please. And I won't go over the intervention too much, but really we wanted to make it family-based because of the multiple caregivers that were involved, and we wanted to make it culturally relevant. So the slogan of our multi-component intervention was which translates to your health is your family's health, because for the Vietnamese community, as in a lot of other communities, they don't want the focus on them. They didn't want to, have their own needs addressed. They really just cared about the person with dementia and how to get treatment and care and support for them. So we tried to frame it in a way that they felt by taking care of themselves, they would be taking care of their family members. Next slide, please. And even before the intervention, we interviewed key stakeholders in the community to get their input, and guidance from our community advisory board. And then we piloted the intervention with a small group of caregivers. And I won't go over the results. I'm happy to share the article, but basically the intervention was successful in increasing knowledge about Alzheimer's disease, in reducing stress, and the caregivers shared their experiences, some of them for the very first time, and felt that it was so rewarding to be able to meet other caregivers, because a lot of them said, I didn't know other Vietnamese people in the community went through this, or had family members with dementia. And so it was really great to see them build these bonds and relationships with each other, and a lot of them shared their contact information so that even after the intervention they could stay in touch and stay connected. So that was really rewarding. Next slide, please. And so again, that led me to think about not only caregivers, but loss and trauma. And so in this next study that I'll talk about in the next couple minutes is the Vietnamese Insights into Aging program. This is an R01 funded by NIA in collaboration with my colleague Vanta Park at UCSF, as well as our community partners who we really could not do the study without ARI and ICANN. Next slide too, please. This is a conceptual model of the goals of our study. So essentially we want to be able to study these exposures to adversity, to wartime trauma, and examine how those exposures now associate with current day cognitive outcomes in an older Vietnamese population, and look at risks for Alzheimer's disease related dementias. And our hypotheses is that that having a lot of these early life adverse experiences contributes to cognitive impairment. And part of that is explained by cardiovascular disease and health risk factors. And we try to account for things like acculturation level, social support, and depression, SES in our model. Next slide, please. So the goals were to recruit a cohort of 540 older Vietnamese Americans into the VIP, approximately half in Sacramento and half in Santa Clara, and to follow them longitudinally and assess them every year for several years. We do a complete neuropsych assessment on them. We interview them about their early life in Vietnam and how they got to the US. And the interview itself at the baseline was about 3.5 hours, and we are currently in wave 3 of our assessments. Next slide. And we actually started off this study right in the height of COVID, so we were really concerned about how to be able to do this. But we partnered with ARI as an example, and Van did similar things at UCSF in San Jose. But we went to flu and COVID-19 vaccine clinics to pass out flyers. We went to food distribution events that ARI was having and just was a part of that with them. Next slide. And we had our official VIP launch in October of 2021 during a food distribution event. And again, it was just a way to be a part of the community, to get to know them, and to tell them about opportunities for research. Next slide, please. And it's been great because since that time, we've had an annual Vietnamese mini medical school. So that's just what the term implies. It's a mini medical school for community members in language to learn about different health conditions. During COVID, we talked about COVID-19. Next slide, please. In 2023, we had different doctors come talk about colon, stomach cancer screening, diabetes, normal and abnormal aging. Next slide, please. And this is our most recent, we've been able to do this every year in collaboration with ARI. And every year we've had increasing numbers of older Vietnamese Americans come out. And so it's just been a great tool for retention as well as just engagement and connection to the community. And a lot of those people pictured in that photo on the right is also from our community advisory board, who participate in a lot of what we're doing. Next slide, please. Oh, I did have one extra slide I forgot that I had included, but that's okay. It was just some of the data that I wanted to show from our recent, most recent paper, but I can just talk you through it. It's really quickly, but basically our goal was to recruit 540 individuals. We ended up with baseline data for 548. And actually, we had a huge wait list before we even started the study because people were so excited to be able to participate in research. So that was really encouraging, just to know that Vietnamese people want to participate in research. They had just not been asked. And so we had 548 people at baseline, about half are women. And what we learned from our study, and I'll show the QR code in a second, you can read the paper, but we found really high vascular risk factors for this population, that about 74% report hypertension, 80% high cholesterol, 40% diabetes. We found really high exposure to traumatic experiences. So 51% reported having to move or get evacuated at the last minute from their home. 50% had seen dead or mortally injured civilians. 40% had a fear of being injured or killed in wartime, and 50% had a friend or knew someone who was killed near the battle. So 1 in 2 individuals, and that's really a high rate of the traumatic exposures. And soon we're going to start looking at how these exposures are related to cognition in this group. So I'll end with this last slide for conclusions and future directions. Next bullet point, please. So I just want to highlight how important it is that community engagement and outreach happen before the research is being done when we're trying to engage communities. We spent several years building the relationship with ARI, our nonprofit, talking to their executive director, talking to their staff, learning from them before we even went out into the community. And so it's about building trust and building rapport, especially in a population that has had such traumatic experiences and distrust of the government. I think that's my next bullet point, is to really consider the sociocultural and historical context of research participants and their families, that they come from a background where they couldn't trust their own government. And so building that credibility in the beginning was really, really important for us. And, that takes time and that takes effort. But just the success of our recruitment shows that it was a necessary and important part of our research. Next bullet point, please. And I want to highlight, just the inclusion, how important it is to include AA and HPI groups in dementia, in caregiving research, because they are so underrepresented. And I think this is a social justice as well as a scientific imperative. There are these new Alzheimer's disease treatments that are coming out, and we know so little about how they're going to do in Asian American populations, and the possible risks of these treatments. And whether or not they'll benefit Asian American individuals. And so I think it's really important that for them to not be excluded from these clinical trials and from research in general, is important to be able to study their prevalence, cognitive impairment, and having these studies on ApoE, for example. And I think it's a scientific imperative because it's an opportunity for us to study risk as well as resilience. A lot of these individuals face the very same early life exposures of war and escape. And yet some of them develop dementia and others don't, and are resilient. And what are the factors that are contributing to this resilience? And I think that has implications for studying other minoritized and understudied groups as well. And I just want to end with this last quote. This is a quote from a 72-year-old that we interviewed in VIP, and this is a study that will be published soon in the Journals of Gerontology by my postdoc. And in talking about his time in Vietnam and escaping, he talks about how he felt lucky that he had this sense of gratitude that he survived. So he says, compared to our lives before, the living conditions in the refugee camp were precious. We had food and water. We felt like our lives had changed already. We no longer were afraid. So despite all of these traumatic circumstances, he and others felt, this was a salient theme throughout the interviews, that someone was looking after them, or that there was a sense of gratitude and feeling blessed that they had survived and that they had made it to the US. So with that, I just want to acknowledge in this next slide my funders, NIA, Alzheimer's Association, my community advisory board, and my community partners and staff and research participants. Those are the QR codes for the articles that I referenced in my presentation and my email address, and I'm happy to answer questions. Thank you so much.
Dr. Meyer, thank you so much. You've given us a lot of food for thought here, because we, as a nation that welcome immigrants, have historically many from war-torn countries. This will give us a lot more information and understanding of what the trauma informed and how to move forward. More importantly, I just want to kind of just highlight too that I love the fact that and most researchers in this room, and I'm sure who are listening in, are going, wow, she filled her entire cohort and she did it quickly. So the idea of getting out there and getting to know the community first, educating the community around their health is paramount. So applaud 100 times over to you. So now we're going to move on to Dr. Fayron Epps, who's also working with a minority population and has had some significant success working with faith-based in the Black community. So Dr. Meyer, if you'll hang on, again, we will be doing a multi-speaker Q&A in a short while. And so we look forward to that. So Dr. Epps, you're cued in, I hope.
Yes, I am here. Good afternoon, everyone. Let me find my PowerPoint. I just had it up, y'all. I'm sorry.
You can do slides or we can. Which do you prefer?
Oh, you know what? You could do the slides. If you have it, go ahead. All right, so good afternoon again. I'm here this afternoon to speak about the role of the Black church in meeting the needs of families affected by dementia. I am the founder of Alter Dementia, but also professor and endowed chair of caregiving research at UT Health San Antonio in the School of Nursing. So as we go into the next slide, I would just give an overview of the Alter program that we're going to talk about, and I'm going to share its journey on how we're meeting the needs of the Black community. But in the Alter program, we provide dementia-related education to African-American-based, faith-based communities, and we are equipping them with the resources that they need so they can better serve their parishioners and the community at large. So our aim, our goals are to promote positive perception of aging by empowering Black communities to support older adults and caregivers affected by dementia, fostering resilience, and enhancing overall well-being for these families. Next slide. So a little bit more about the Alter program. We exist to encourage a culture change. So we want to alter the perception of dementia in the Black community while strengthening supportive services that are available through the church. We do recognize the church as a care team member, and we make sure we integrate faith-based interventions for family caregivers into our program and when we're working with churches. So when we are working with our faith communities, we want to make sure that they know they are right there at the table when they are having care team meetings, when they're trying to discuss the support system for one of their fellow parishioners, that the church should be right there. Also provides educational resources to congregations. Our goal is to innovatively transform the support system that exists in the Black community, transform the support system that is available for Black churches. We want to equip the Black leaders, faith leaders, with the skills that they need to advocate for dementia caregivers, persons living with dementia, and then promote their overall well-being. And we're doing this through inclusive practices that we're coaching the churches to do. And many times we may say, oh, faith communities, they should already know this and they should be doing this, but that's not the case. And when we're doing this, we're fostering empathy and support for these families that have been affected by dementia, because many of them have left the faith community and they are out there without resources. They cannot access the healthcare system. They don't feel comfortable going back to the church. So we're trying to change that and make sure that they feel comfortable to go back to the church. And then our churches are equipped and prepared for them. Next slide. So within our program, we're addressing critical issues, right? There are, and many people already know the disparities that exist in the Black community. I think I've been doing this work a little bit over 10 years, and the statistic is the same, that Black individuals twice more likely than our white counterparts to be diagnosed with a form of dementia. By 2030, nearly 40% of individuals living with Alzheimer's disease or form of dementia will be Black or Latino. You know, so these disparities exist, and we want to address that. We also do this through partnerships. And so we are seeking to bridge these gaps by leveraging the trusted role of our faith communities to implement the ALTER program. So again, in many of the communities that we work with, there traditionally have been underserved, overlooked, is what I actually hear from faith leaders. Like, no one sees us. And we are bringing this program to them. They are not the last on the list. They are actually the first on the list. And so now they feel that they're being seen. And we're able to help the community through these partnerships. And we are urgently addressing the escalating impact of dementia in the Black community and providing culturally responsive programs to support networks to address dementia. Or address these disparities, I should say. And so one of the things in this bullet is culturally responsive programs. And so that is programs that is responding to a need of our cultural group. This is so important. Many times we bring our own programming in, but that's not what the community need, or it's not what they ask for. And with the ALTER program, we are truly listening to what our communities need. And each church is different. Each geographic location where they are, it is different. And we have to be able to tailor the program, the framework that they're using to meet their needs. Next slide. And so I share this because this is the overall conceptual model that I put together maybe about 6-7 years ago when I just had this ideal and I was working with some colleagues and was like, okay, what can we do here? You know, because when I was living in Atlanta, a lot of the Black churches and leaders they didn't have the resources and they wanted it. And so I did some earlier research that was funded by the Alzheimer's Association to help craft this model, and we understanding the stressors that these families go through. And then we want to create these dementia-friendly congregations, and you can see these different spokes that's coming out of that we work on, and in return, we should see family well-being. Next slide. Oh, I know this is busy. I just have to put this in there. I know you probably cannot read it, but I just want to let you all know that this is just not something we woke up and did. A lot of work went into this where we had to do a logic model. My background is nursing. I wasn't taught how to do a logic model and come up with programming, but this is something that I want to say on the job training, we should say. And so our team worked together. And so we are truly following this. We're looking at our inputs, the activities, the outputs, and then what are those outcomes at the individual level, the community level, but also the organizational level. And so we've been doing this work for about 5 years, and we are just like slicing it up because it is a lot to be able to manage, address, and measure. Next slide. So many of you all may be thinking, okay, the ALTER program, you're working with churches, what does that look like, right? And it is a 2-year partnership that we're asking our faith communities to commit to us. 2 years of them implementing activities that I'll discuss in a couple in later slides. They also get a welcome box, which I call it a starter kit of how they can start this ministry. So many of you all can just think of this as we're working with these faith communities to start a ministry to address dementia in their community, to support those living with dementia, but also to promote risk reduction, to reduce the risk of dementia. And so we create a box and we mail that to them, and that's their starter kit. Our faith communities have to sign a memorandum of understanding. So it is an application process. We do not accept every faith community that comes to us because we're looking at the readiness level of them implementing a program, making sure that they have staff available. They don't have to have people in their congregation living with dementia because many of them they don't know. And they end up having a caregiver there, maybe someone experiencing cognitive impairment. But what we need is making sure that leadership is on board and they have a ministry or identified an ambassador that we can work with and we can train. We do provide financial contribution for them to start this ministry. Many times we go out in the community, we want to work with organizations, community-based organizations to roll out programs, but sometimes we don't bring that financial support. And that is so important because at first we weren't doing that. Then we seen, oh, well, we have to put it in our budget for next year. So that's 12 months of families going without services and support. So we give a modest contribution of $1,000 for them to get started. And then we teach them how to apply for additional grants and support so they can keep their programming going. Our faith communities do agree to implement 16 initiatives over this 2-year period. And again, it's for them to become a dementia-friendly congregation, a dementia-friendly faith space. So that's what all of these activities are geared toward. And then after the 2-year period, they have an opportunity to become a legacy partner where now they can support other faith communities. And then when you're becoming a legacy partner, you're looking at 8 of those 16 activities that you initiated, 8 that you did really well. And those are the ones that you will continue doing and offering to your parishioners and to your community. Next slide. So, like I said, we do not accept every church. And some of the main criteria is related to they serve primarily African-American parishioners. They can identify members in a congregation or in the community that may be living with dementia, and they're willing to participate and implement 16 activities. Next slide. And I will tell you the hold up when we look at that, a lot of people are like, oh, we got to do 16 initiatives, but we work with them. They do a timeline. They're assigned a coach or a liaison to make sure we hold them accountable. And we've also had faith communities that come together and say, you know what? We're a smaller congregation, but we want to partner with these other 2 churches that's on our block to implement these activities. And that has happened. So the Altar program has 3 key pillars. It's support, education, and worship. And this is what we are working with our churches to do: increase their supportive services that they offer, educate and awareness. And then also what's a little different than a lot of other programs, we do work with our leaders to see how we can modify those worship services so these families can still spiritually connect. Next slide. So here are some examples, and I will tell you, we don't do this alone. We partner with a lot of agencies and probably some folks that have came here to present as well, where we partner with them to implement memory cafes within our Black faith communities. Support groups. We partner a lot with the Alzheimer's Association. Sometimes our churches will go to them so they can create a Black specific support group, and they just learn from them how to facilitate. Respite programs, we've partnered with Respite for All. We've also have worked with our churches to give respite scholarships to their caregivers, supply closet for families. So that's all under support. And y'all, these are just examples. They have a long list that they can select from. Education, they can do memory, Purple Sunday, a virtual dementia experience. They can do dementia or brain health education. We encourage them to include the youth. They have done fundraising events. We have worked with just all other agencies and partners just to create these education and awareness events that our churches can connect with. And then as it relates to worship, these are just few of the examples, but our churches have to select at least 3 items under this bucket, and either they're going to shorten the service length. And so if they're in person, many times in the Black community, pre-pandemic for sure, church services could be from 2 hours to 3 hours plus. And I had actually my research team, we went to several churches because we wanted to sit down and observe this. And so now we are encouraging them to do 75 minutes or less if it's in person. If it's online, we say 10 minutes or less. And again, I was able to write a grant funded by the Alzheimer's Association to create and test these online worship services. And so now we have faith communities out there using those services that are available on YouTube, creating their own or doing some version of that. We have churches that created sermonettes, and then little short snippets of hymns and songs that they put on their own YouTube channel. Familiar prayers and the use of visual aids, high proportion of music as well. So again, these are some examples, and we're educating our leaders on how this can support those living with dementia and also their caregivers. Next slide. So where are we? So we started this program, 2020 is when we signed our first church, but really putting this program together in 2019. And we are in 105 faith communities across 21 states. And these faith communities are not all individual churches. Some of them are alliances, districts, conferences. It depends on the denomination that we work with. We're currently in all Christian denominations, but we're open to work with whatever denomination it is where Black people gather to worship. We are there to support them. So it's 21 states, 56 cities. We have 14 faith denominations that we're working with. And y'all, this is growing. We actually had to cap this as our planning for 2025. We're only going to be able to bring on up to 50 churches this year. But this last year, within 6 months, we onboarded 34 churches. So within year 4 and 5, this has really, the uptake of this in the Black faith community has really picked up. And it's a lot of word of mouth right now, that our faith leaders are calling another faith leader and saying, you need to get this program. We have families that's bringing it to their churches. So I just want to give y'all a snapshot of where we are. You can see we are flooding Southeast United States and going up East Coast, little Midwest. I mean, we are really flooding. And that makes sense, right? Because that's the Bible Belt as well. If you think about it, it starts right there around Louisiana and it goes all the way up, got Tennessee, all of that. And so I recently relocated to San Antonio, Texas this summer. And one of my reasons why is when I look at this map, it should be really obvious to y'all why I need to come over here, because there are so many Black communities, so many Black faith communities that are not getting these services, are not creating these support programs for their parishioners. They're not doing brain health education, risk reduction, and I want to change that. And so within 6 months of me being here, we have onboarded 6 churches in the Dallas-Fort Worth area. We have 6 in San Antonio. So that is really growing. We have brought in some folks from Nevada, some more people in California, Nebraska. We just brought somebody in last month from that area. So it was really important. So for those that say, why did you move to San Antonio? This was the reason for me to move, for me to make sure that I can have a greater reach and help more families. Next slide. So while I'm telling you about this program, I am a nurse scientist and nurse researcher. And so we do embed research. One of those things that our churches can select is them sharing research opportunities. That falls under education and awareness with their congregation. And so I share my research studies. I also have colleagues that come to me and they invest in the churches and they share their research opportunities. And here's an example of where we went in Georgia over, I think it was a 12-month period, and we were able to survey close to 1,200 parishioners in churches in Georgia to create this measure of dementia friendliness, because there was no measure true. People gave a concept, this is what you should measure, but it wasn't a tool. And so again, we received funding from the Alzheimer's Association to create this measurement tool. And we will be presenting the results this year, but I can tell you preliminary results actually show that as congregants rated their church, the more dementia friendly they rated it, the lower their stigma was toward dementia. And so we're looking forward to being able to really finalize those results and share that. But again, this is an opportunity for our congregations also to get involved in research. And we do a lot of this, and people, they didn't think this would happen at all. But these churches open up their doors on Sunday after worship and created these environments for their members to learn about research opportunities, to participate in this study, which was really, really, really amazing and surprising for some. And so I actually coined our Sundays called Worship and Research when we used to go out. And so I just wanted to share that because it can be done. And again, this is not a hard to reach population. We just have to go to them and think of innovative ways to get them involved and bring the support in research opportunities. Next slide. So our overall expected outcomes for the ALTER program, we want to increase awareness and understanding of dementia within Black faith communities, within the Black community. We want to establish the supportive infrastructure to facilitate dementia-friendly initiatives within these communities. Enhance the capacity of our Black faith communities to support dementia caregivers, to support these families that are on this journey. We want to make sure, again, that our faith communities have the resources, because not just in the Black community, in many communities, when you're troubled and you have issues, many people go to their leaders, they go to their church, but we were noticing that our churches did not know how to respond. They didn't know what dementia was themselves. They didn't know what to do. And it really stood out to me one day after I did an education a while back when a bishop came to me and said, "So what am I supposed to do with this?" And y'all, that's where this program was birthed. Right when he said that, what am I supposed to do with this? Because we all say education is great, but he was letting me know he needed coaching. He needed to know how to transform his congregation, how to better support his parishioners. Next slide. So I just want to recap the timeline so you can see where we started and where we are. So I mentioned earlier, 2018, we was doing education, just doing that education out in the Atlanta area. 2 churches whoever opened up their doors, me and some colleagues would come on a Saturday and just educate. Sometimes 3 people came, and then eventually it was like 80, 100 people, and it got to be a lot because the word had really got out that somebody was talking about this that was happening in the Black community, and no one else was really addressing this and having these honest conversations, these courageous conversations. That's anyone that goes to one of our education events. We talk about everything that could be surrounding this. So racial discrimination, the things that are happening in society, how it may affect you. We talk about that. We give them that space to address that. In 2020 is when we created we created the program, and we partnered with our first church, January 2020, right before the pandemic. And we thought everything was over once March came. But actually, that's when we seen an increase, and faith leaders started calling us. Because now everyone they stayed still. They was able to pick up on signs and symptoms. And so they started calling their pastor, and then in return, the pastor was calling us. In 2022, we expanded outside of Georgia. So this was started off as this little pilot project in Georgia, 24 churches. Let me see if this worked. Well, in 2022, we started getting interest outside of Georgia, and it was actually from one of our partners in University of Minnesota. And we started accepting more churches outside of Georgia. In 2024, we held our first annual ALTER Dementia Summit. And this was amazing. This was, again, responding to the community. Our faith leaders said, this is great, but we need to come together and get more tips. We need to create more solutions for our community. We need to invite people, because everyone couldn't do the 16 initiatives. And so they was feeling left out. Now with the summit, they can come and they can take away 2 things that they can go and implement within their congregation or community. And looking forward in 2026, we are working to train public health agencies to roll out this program because we cannot reach everybody, to have a small team, and also to expand to other racial and ethnic groups. We're also having conversations. I know Dr. Flatt presented earlier, but we're working with the Open and Affirming organization. I think I might have gotten it wrong, but there's Open and Affirming churches, and we're now having conversations with them to see how we can bring this framework into their faith spaces. Next slide. So again, as our next steps, I talked about what 2026 and beyond looks like. It's actually starting in 2025. We want to collaborate with public health agencies to help disseminate this program. We plan to continue to raise dementia awareness and do this education and outreach within our faith communities. And then we are really looking to translate this program to other faith communities that serve diverse groups. And so we have a lot of conversations in the beginning conversations that's going on to see how this program and this model can be adapted and used in other communities. And I know it can. I know it can. It's just making sure that we are responding to their needs, and especially if it's a particular faith community, that we make sure that their doctrine is aligning with the framework. Next slide. So sustainability, I think the biggest thing is, a lot of people say, how can you keep doing this work? And I'm going to tell you all, some days I don't know how I can keep doing this work, but it's when I get that phone call from that faith leader saying, you're the only person I knew to call to help my parishioner. She doesn't want to talk to the association. She doesn't want to talk to this. And so they trust me. And so realizing that, when I get those calls from the caregivers, or when caregivers see me out in at the grocery store, or they're coming to a church because they heard I was going to be there and they traveled to get there and got their loved one there. Y'all, that's what keeps me going. And that is why I know our goal is to eventually have a formal coordinating center so we can coordinate these efforts. Because right now I got a team everywhere. I got a team in Georgia, I got Minnesota, I got a couple of states, I'm here in Texas. And sometimes it's hard and things do fall through, to be honest with you. And so we would like to do that. We also want to work with PICO out of University of Minnesota, help us be able to scale this out. We do solicit a lot of sponsorship, and we're looking at doing licensing fees so other programs or other agencies can really pick this up and can have that reach. So this is not really not my program at all. It is for the community. And that's what this is all about, how we can get this in these areas that have been overlooked, underserved, and we can change that narrative as it relates to these disparities that are existing specifically in the Black community. Next slide. So this is our website. Feel free to visit to learn more of the things that we're doing, our resources. We have a map where you can see our communities and everything. Next slide. I also want to share our upcoming summit that will be in Atlanta in April the 10th to the 12th. We have everybody coming. So we have our faith leaders, caregivers, persons living with dementia. We also have researchers, scientists, healthcare professionals. They're all coming together so we can learn from each other, but also we can create some solutions that will help particularly the Black community. So I do want to invite all of you, if you're in the Atlanta area or want to travel to Atlanta, please do come by. This is not just an educational summit, it is an experience. And we've posted a lot on social media about this, but when you know your audience and you know your community, you create this experience that they would want to come to and learn. And that's what this is about. So it has a gospel concert, it has a play, it has the things that exist in a Black community. and it has education and research built in. So it's really beautiful. It's really beautiful. So I hope to see some of you all there in April. Next slide. I do want to acknowledge a lot of people say, well, how do you do this? And the support, the financial support, the in-kind support. Y'all, these are all the agencies, universities, my partners that have really, they say, we want to be on board. We want to join this movement in some form or fashion. So if it's either them providing money support, providing personnel, any other in-kind support, they have been on board with us to get us to this point. The sites, the bullets with the asterisk, these are actually our sites. So we do have 4 sites where we have a site coordinator in Minnesota, Pittsburgh, Virginia, and Mississippi. Those are the areas that we have trained them. There are folks that's on the ground that's helping us in those areas to get this out. So we're hoping to expand that and have more sites. Next slide. So again, hopefully I didn't go over my time. I thank you for your interest and your invitation for me to share more about the Alter program. On here, you can see our contact information. We are very active on social media, so please do follow us on Facebook, Instagram, X, LinkedIn, and now we're on TikTok, and I think that's alter.dementia. So I'm super excited to see we already got 200 and something folks following us on TikTok. So we're super excited to really get that out. Because again, it is to bring these services, support, education, outreach to the Black community. Thank you.
Oh my goodness, Fayron. I think you've gotten us all excited here about what is possible. You talked about community, community, community. And so have our preceding speakers, because that's where it's at, right? We've got to get to the people in their homes, in their churches, in their senior centers, wherever they are. That's how we will educate. That's how we will destigmatize this term dementia. So in this disease, and they will have the ability then to outreach to others, and then the researchers, the clinicians, and all the rest will learn from their experience. So thank you. I am now going to turn it over. We have approximately a little less than 15 minutes to handle Q&A before our break. But Susan DeMorris, another one of my council members. Susan, if you're in the room, if you will handle the Q&A.
I'm so happy to, Helen. Thank you. And thank you to each of our presenters. I have copious notes here. Just, clapping hand emoji for every single one of you. What I heard was, in each of yours, there were examples of helping one person, 2 people, 5, 10, hearing growing to 80 people coming out. So let's talk about scalability and how some of these efforts could be replicated in other, Fayron, I love your map showing where we need to go. But let's talk about, balancing, keeping things small, intimate, a circle of trust, and taking these efforts to scale to reach more people. And then if we have any, I can't see people in the room. Let's start with any questions from council members in the room.
Yeah. Adrian, of course, I always have questions.
Please go first, Adrian.
I'm going to start with Christine in Alaska. I was struck with how remote your place is, but can you talk about the acceptability of supporting these through telehealth? What is culturally appropriate to do that? Some of the barriers or resources or best practices in that setting. You mentioned radio. So I wondered how much telehealth is a possibility in Alaska.
It's funny because I had started this morning by sending a rather panicked email to Helen saying, I'm waiting in the waiting room. The reason for that panic was indeed connectivity is a bit of an issue up here. And I wanted to make sure I didn't miss my opportunity to talk to you guys. So telehealth is indeed socially acceptable. The problem is connectivity. So we do have a long time ago, we figured out that Alaska is so remote, we needed to be able to do telehealth. And in some ways, we were ahead of the curve. For instance, ENT has been using it to take pictures of kids' ears in villages for over 25 years. The problem is getting it from the clinics to the patient's home in terms of services, because I want to be able to see that dementia patient in their home, to know what infrastructure they have, to know what trip hazards they have in the home, to know how many people are there, how they're actually living, because everybody gets dressed up and goes to the clinic is on their best behavior. So we want to make sure that we're really helping in a true and realistic way. And that is a true barrier, because it's very, very expensive to have internet here. And the devices are very expensive. So the clinics have devices and they have better connectivity. But if you want to have services in the home, that's where it gets difficult. And in the winter, there's no roads in the villages either. So you're trying to get an elder with dementia on the back of a four-wheeler over to a clinic, which could be a mile away. Some people are taking their clothes to the washateria, dragging them on a sled. So trying to have services get into the home are very difficult. Radio really is a thing. Our radios go into every home. Patients have them on in the villages all day long. I really think that even though it sounds very old school, that having elders talk about brain health on the radio is going to be one of the most effective ways that we can get dementia education out to our community. So don't want to take up everybody else's time. I hope that answers the question.
Excellent. Thank you very
Christine.
much.
Thank you. Is there
I
anyone
have-
else in the room with a question before we go to Brother John Richard?
I had a-
Go ahead, Adrian.
Yeah, just ask a second question. I was struck with the presentation on Vietnamese. And the thing that struck with me on the presentation, the slide that you had about the educational background of the different groups that come, and how much information you showed about the trauma. And I don't know that we really focused much about that when we think about dementia caregivers and people living with dementia, how much trauma informed is going to be one of the issues we need to deal with. So I wanted to thank you for raising those specific issues. So no question, but just a comment. Thank you.
Yeah, thank you for that. And actually, Adriana, I just wanted to comment real quick because you reminded me one of the things that I first dealt with when I was caregiving for my mom and she was starting to exhibit signs of dementia. She was really paranoid, and I saw a lot of the trauma of the war come back, right? Because she tended to have short-term memory loss, but she had all of these long-term memories, and a lot of those were traumatic memories. And so she would close all the blinds, close all the shades, and talk about how the communists were outside her home. And I think that, and I wonder, I don't have enough data on this, but I wonder if that is even more stressful for caregivers, because there is this remembering of the war and all of the bombing that took place, and how to help caregivers deal with that in particular, I think is would be really interesting to look at. But your comment just made me remember that caregiving experience of my own.
Thank you, Dr. Meyer. Now we'll go to Brother John Richard and then Roberta, please.
Susan, I wanted to ask before I go, because I got bumped out of the room for a moment. Is this questions to all the guest speakers today, or just?
Yes.
Okay, good. So, because my question was to Jessica, if is she here? I see. Yeah, there she is. And I was wondering with the on-lock and PACE, how feasible is it to replicate that in rural settings? It looked like it was something that's a very comfortable fit in a big city, but how feasible in rural settings is that? And what kind of work do you see that taking?
Yeah, I thank you for the question, and I appreciate still being here. I'm learning a lot. I would say that it is similar to, I think there is the PACE program, which includes the adult day center and all the wraparound services. But I think like the key part, maybe around the social isolation is the adult day center, which I think does have its own challenges in the rural settings, but still is feasible, for social isolation. I also think that, thinking about the, alternatives using technology, has its pros and cons in rural settings, but I think it's still possible to create connection that can be helpful for that community there.
Thank you.
Thank you, Roberta. You're on mute right now. Yes.
Thanks. Just wanted to thank all of you. It really touched home for me. I'm one of the 2 caregivers and non-federal members that are on this committee. Grew up in the Bay Area, so I'm very close to, both San Francisco and Davis, Sacramento area. In my family, my mother immigrated from the Philippines in '74. And in hearing all of your efforts from Texas, Southeast, California, all the way up to Alaska, it's just very inspiring and refreshing to know that you've been providing this. And I'm thinking to myself, when my mom was with me and when I was taking care of her, that in the midst, I would have loved to be connected, right, to such a very specific, tailored, culturally sensitive and inclusive effort. My question, and really it's so more of a comment and gratitude for the work that you're continuing to do. We know that we need more of that. I guess my question is, beyond the word of mouth and all of you focused on that really important initial stage of building trust and connection. And I found that was something that of all the spaces that I found, I experienced like they weren't specific, right? For an immigrant community, they weren't specific to my mom, who's reverted back to her original language. What are some of the ways, like maybe the top 1 or 2 ways that you focused on building that trust? You spoke a lot about partnering, right? You couldn't do the work without partnering with existing organizations. I guess I'm interested to hear, and we know that that's what needs to happen is building that trust, but I'm always interested to know, what are some specific, can you name those specific things that you do in your specific efforts?
Yeah, thank you, Roberta. And if it's okay, I can respond to that first. Because many people come to me because they feel that I'm that trusted person within this group, especially faith communities. But I would say it's not just one, it's 2 key things that I have done. And it takes time, but it's number 1 is showing up without an ask. So me and my team, and that's something I had to train them to think, you just show up. If a faith community is putting on a jazz concert, you show up. If they're doing an installation of pastors, you show up. If you know this is the community you want to work with, you show up. You don't have to have an ask for them. You just show up at their events. They're looking, they're seeing you. And that's where I started building that trust, because I'm not originally from Atlanta. I'm from Louisiana. So just because I identified as being Black, I still was an outsider. And so I had to show up at these events in the evening and on the weekends, with my family, without my family. We showed up. And number 2, it's being available. So after you show up, once you start sharing your contact information, you can't shut off at 5 o'clock at night. So I do have boundaries. I shut off about 9:30, but especially pastors, they work. And so they start doing their ministry once they get home from work. right? And so that's when they're available. They're available on the weekend. And I have a lot of colleagues that stop working at a certain time. They're not flexible. They do not answer their phone. And so then that's going to be hard for you to build trust where I am available. They can pick up a phone, call me or any member of my team. And we will be able to answer, respond via text or whatever it may be. So it's being available and showing up would be my top two.
Yeah, thanks. I totally agree with Aaron. Same thing. Show up to all the events that they'll have you at. And I think for me, I can relate because I am Vietnamese American, but born in the US. You know, my first language was Vietnamese, but it's what I lost it quickly, right? Once I went to school. And so for me, it was making an effort to speak a language that I felt uncomfortable, and it was really a humbling process because I actually went to a junior college when I was a postdoc and took a Vietnamese language class, and it kind of brought back a lot of what I learned when I was like 4 or 5. But making that effort, whatever it takes, and having that humility to say, this is uncomfortable for me, but I'm going to do it because I feel like it's valuable and I want to build that relationship. And so even now when I'm, doing presentations at, at community events like the Vietnamese Mini Medical School, I have to, speak in Vietnamese, and I'm sure it's, really funny for people to listen to, but it's making that effort. And I feel like people really appreciate that. A lot of the older Vietnamese are like, oh, it's so sweet that you're trying to learn it, or that you're, doing your best. And I think just showing up, making that effort, even if it's uncomfortable, is a practical that I would say.
Thank you. And we have time for one final question. We'll hear from Maria Teresa.
Thanks, Susan. This question is for Dr. Meyer. So I want to thank you for mentioning the importance of acculturation in your presentation. I was wondering if it's a two-part question. So when you talked about the caregiver intervention, could you speak a little bit about how you quantified acculturation? And then for individuals who are looking to expand community engagement and really do outreach to specific communities, how might they be better able to consider the experiences of acculturation in the context of caregivers and dementia?
Yeah, thank you for that great question. Unfortunately, in Vietnamese, there's not a well-validated measure of acculturation, but what we have used as proxies of acculturation are English language proficiency, how long people have been in the US, generational status, what generation they are. But those are just proxies. But I think how it shows up in working with caregivers and the intervention is, for example, I had a family who the dad was not very acculturated, born and raised in Vietnam, lived there most of his life, and his daughter, who was the primary or one of the primary caregivers for the mom, was trying to convince him, this is dementia, this is Alzheimer's disease, it's a neurodegenerative disorder, it's not caused by he was trying to get her holistic health and alternative remedies, and saying we need to just pray it away, or things like that. And this drastic acculturation difference between parent and child was really contributing to this conflict. So what we did in our intervention is try to have them understand the perspective of where each other were coming from, that there are different beliefs about etiology of dementia depending on how you were raised, depending on your acculturation level, that they didn't have to, even though they disagreed about the etiology, they could agree about where to get support and where to get care and how to get IHSS, very practical things that even their differences in beliefs didn't have to prevent them from being on the same page. So things like that, I think, really taking into account the acculturation level of each person, the caregiver, the care recipient, other family members, and how that influences what they believe about dementia and what they believe caregiving is what we try to do in our research. I hope that helps.
Yes,
you,
thank you.
Dr. Meyer. And I turn it back to Helen now.
Thanks, Susan. I'm here. All
Okay, there
right,
you go.
everyone. We've got, yes, I'm here. We've got 10-minute break, and I'll look forward to seeing council members back at 3:15.
Produced by the U.S. Department of Health and Human Services.